Welcome students, this is Christy Day and I wanted to go over just a little bit about the physiology of clotting. And this is not intended to be a comprehensive review, but it's just sort of an overview. There's a lot more you can study, and there's a lot more that you can learn on this clotting cascade. But I'm just intending this as sort of a quick review so that you can get started on studying for your anticoagulation. If you look at this chart right here, it's a very simplified version of the clotting cascade. And this is found on YouTube. You can see this other places, and that's where I got the idea for it. But if you look here, you have the intrinsic pathway, you have the extrinsic pathway, and they converge to form the common pathway. And listed upon here are clotting factors, and these have different names that you can look up and study, but it's not critical that you do that. And also the extrinsic pathway has the names of the drugs. It shows that calcium is an important ingredient here for on the clotting cascade. And this factor 10A and 10 is where some of the newer drugs will act. So up here on the top, I have indicated that the intrinsic is monitored by PTT and the extrinsic pathway is monitored by PT. And if you look down here at the common pathway, we see it's monitored by INR. INR is actually just a ratio of the PT. So they're actually the same thing. It's just looked at in a different way. It's a calculated result. Okay, so you can see up here that I have the extrinsic is in blue, and over here in blue I have indicated warfarin acts mostly on the extrinsic pathway. Now if you look at the actual cascade and the drug information, there is some activity down here, but it's generally considered that warfarin acts on the extrinsic pathway. Okay, and you can see that warfarin has an antidote. Is vitamin K will help reverse the warfarin here on this pathway. Warfarin can be prothrombotic at the start, so sometimes you need other drugs in addition to warfarin until it gets past that and it becomes therapeutic. And warfarin requires frequent monitoring of PT-INR. I'm sure y'all are all aware of this very acutely, that it's usually monthly. We have to monitor that. And if you think of the indications for warfarin, and you think of the problems that you're trying to prevent, like strokes, heart attacks, pulmonary embolism, that are all deadly, if you think of those and you think of this drug being underdosed and the PT-INR not being therapeutic, then you're putting your patient at risk for those problems. So it has a narrow therapeutic range, and that means if it's too low, it's not working. And if it's too high, it's toxic. So we've got to get this in regulated into the therapeutic range, and I'm sure y'all have seen those ranges on lots of reports. The other problem is it can be affected by diet and medication, so that you may have a PT-INR that is good 1 month, and then you start them on an antibiotic or some other drug, or they eat too much leafy green vegetables, and now we've got too much. It's too high or too low. So the actual drug is cheap, but when you factor in the cost of monitoring, and not only in laboratory tests, but people taking the time to evaluate these reports, make adjustments, communicate with the patient, fill prescriptions, there's quite a bit of cost associated with this frequent monitoring. So the drug is cheap, but the monitoring has some costs associated with it. Now on the green side over here under intrinsic, you can see that heparin is here, and heparin is IV. That's in acute care, so that's not something that we use in primary care. And then Lovenox, you will see patients on Lovenox who are coming out of the hospital. They may be on it for quite some time, couple weeks, a month, something like that. So this pathway is occurring at the same time as another process is going on, and that's with the platelets. When the lining of a blood vessel is damaged, platelets immediately form a plug at the site of the injury, while at the same time the clotting cascade begins. So you have platelets that are adhering with other chemical bonds that are created within the vessels. And you have the clotting cascade occurring at the same time as you have platelet aggregation. And we know that our arterial thrombi on atherosclerotic lesions are rich in platelets. So we have an injury to the endothelial lining of the blood vessel, and we start to have platelets go there and adhere. And this is considered a white clot. These white clots are rich in platelets, and they've been traditionally treated with antiplatelet medications such as aspirin and Plavix. Okay, on the other hand, we have venous thrombosis, which has traditionally been associated with red blood cells and fibrin-rich red clot. So fibrin is down here, and it's red and cluttered. We know as clots age that they can change and become a little more red, but these are just kind of your catch-all. There's exceptions to every rule, and we're talking kind of generalities here, just kind of to give you a baseline. So these problems, or venous thrombosis, are traditionally treated with heparin and warfarin. Okay, but the newer drugs, you can see the trans, that's the suffix, you can learn them that way. Pradaxa is in there, the prototype, and it inhibits factor 10A. So look up here at the chart and you can see where it's acting. Now, if you look at the warfarin, its major action is on 7, and that's right at the top of the clotting. So we're kind of poisoning this whole clotting cascade. Whereas with these newer drugs, they're starting lower down here. They act lower on the clotting cascade, which is less impact on that, on your clotting and your natural cascade there. So the bands like Xarelto, and you can pronounce that yourself, I haven't practiced it too much, act directly on the thrombin. They're a thrombin inhibitor, and you can see that's down here. So the advantage of these drugs is that they're oral. They have no PTINR monitoring. You might have to monitor for liver and or renal function, just like you would with any other drug. Look at monitoring, but you don't have to monitor coagulation. Now, the problem is that if you're not monitoring PTINR, your first indication of too much drug is bleeding. Whereas with the warfarin, you're doing your PTINRs and you will often catch a high INR before bleeding starts, so you don't have the bleeding. And they say that there's an antidote of vitamin K. Vitamin K takes about at least 8 hours to work. So the advantage to these drugs down here is that they have a short half-life. And so you may have a 6 to 8 hour half-life, and or you can look that up. They're different, for different drugs. But so this is going to be clearing, and there's no antidote, but they will sometimes give platelets to act on the actual bleeding site. So there's no antidote to the drug, but there's a treatment for the bleeding. So this warfarin has been around a long time. We know it very well. We use it all the time. It's cheap, but it has some problems. And also these newer drugs have their own set of issues as far as, no antidote and some advantages. So this is intended to be sort of a springboard for you to learn. It's not a comprehensive review, but just a way to look at these antiplatelet classes of drugs that can start you on your learning.